present to you and also to learn from you as well. And of course, we're all here to learn so that we can take care of our patients better. So I do have some disclosures, and one of them is relevant since I have done a little bit of work with Ivantis, which I'll be talking about later today as well. So I think in general, when we're trying to think about is a minimally invasive glaucoma surgery right for us, we first need to think more broadly, is it really part of the surgical plan at all? And if it is part of the surgical plan, then exactly what procedure should we be considering? And of course, we must list these procedures to what you're comfortable with and what is economically feasible, especially in the developing world. Yeah. So let's just talk about first whether MIGS should be part of the surgical plan. So I think the best decision should be made upon evidence, but oftentimes, even when we read the literature, we don't necessarily get the evidence we need. And so I think that's why these symposium are very important. I think we're often told what is the success rate for achieving different pressure levels and percent lowering, but these pressure levels that are shown in the publications may not have matched to what your goal was for your specific patient. Generally, when we see reports of what the intraocular pressure was after a surgery, those are for those who succeeded in the procedure, not who went on to have another surgery. So, of course, those are the IOPs of the successes, not the IOPs of the failure. So you have to keep that in mind as well. We also have to keep in mind, and I think this is maybe one push towards thinking about surgery other than trabeculectomy, is that if 99 out of 100 people do well, and one person has a very severe complication and goes blind from that procedure, you have to weigh that more than small changes that may happen in other people. So those infrequent but very catastrophic complications are very important to us, and we can't ignore them because one person's life has been very, very severely affected. I also make this point to our fellows all the time. It is not just how an operation succeeds or whether it succeeds, but if it fails and when it fails and how it fails. So an operation that can suddenly go from a pressure of 15 to 40 at any time after surgery, for example, and some of these newer procedures can have those problems, it can be a problem because it's not realistic to see people constantly. So we need to have something which fails gradually and in a gentle way, and then how something fails is important as how it succeeds. And finally, is the surgery realistic for you as a practitioner and for your patients, given what they are expecting and what their economic realities are? When we get into the nitty-gritty of how you make a surgical decision, I think there's two main things that we need to think about, and those are lens status and the status of the angle, and we'll talk through each of these individually. We'll first talk about phakic patients, because I think that probably is the majority of what you're seeing over here. And I think generally there's three options in phakic patients: cataract surgery alone, glaucoma surgery alone, and combining the two. In the setting of a closed angle, we won't talk about as much because I think there's so much evidence that cataract surgery by itself is a very, very viable surgery in angle closure eyes. In a series of studies, Clement Tam in Hong Kong looked at the outcomes in phaco versus phacotrabeculectomy in medically controlled and uncontrolled glaucoma, and the results were very, very similar in the sense that he actually got pretty good results both with regards to IOP, where even with phaco alone you had a pressure of about 16, and the complication rate, of course, with phaco alone was much less than it was with phacotrabeculectomy. So you're getting a fairly good result without many complications. So I think in general we can consider phacoemulsification alone if the pressure goal is not that low, if the damage is not that advanced, or the patient is not highly medication intolerant. And I only really consider phaco plus glaucoma surgery if I'm needing a lower pressure or if the patient is very intolerant of medications, or maybe is unlikely to take those medications because they can't afford them. So I think there's very limited evidence whether any minimally invasive glaucoma procedure really benefits cataract surgery in angle closure. There is one study that looked at goniotomy after GSL and phaco, and the results are almost too good to be true, as Dr. Iyer and I were talking about yesterday, that they found people needed no medicines and nobody needed a reoperation, and the pressure was always 13. So it'd be nice to maybe see some more data on that. There is some data that endocyclophotocoagulation might be a nice adjunct, and there was one study which showed that 72% could get a pressure less than 15 with medications. And so that might be a nice adjunct surgery, especially as the angle need not be open. So even if you have synechial closure and you don't open it with GSL, that you may get some additional benefit. Of course, a trabeculectomy can really get you those very low pressures without medications that you might be looking for in a lot of your patients with advanced angle closure glaucoma, who may be from a rural setting where they have difficulty affording or obtaining medications. So my general algorithm in angle closure glaucoma is cataract alone if there's early disease or medication tolerant, to maybe think about a combined procedure with a less invasive moiety, such as ECP, if you want a little bit lower pressure or maybe fewer medications. And really for those advanced diseases, consider trabeculectomy if there's not much cataract, or phacotrabeculectomy if there is cataract. Let's talk about cataract existing in the setting of an open angle. So I think this is much more complicated because there's now a lot of options for us in glaucoma, which makes our decision making very, very hard. Of course, we can do no surgery with either trabeculoplasty or drops. We can consider a less invasive option, such as trabectome or GAPT or dual blade or iStents or Hydrus, or filtering surgery or some of the newer filtering surgery alternatives, such as the Zen or InFocus PreserFlow. And of course, we can either do these with cataract surgery or without cataract surgery. So there's a lot of permutations of what we can do. And so when we look at all these different options, the question arises, how do we choose within the surgical space? I thought it would be easiest to do a case example to how you kind of work through this kind of complex decision making. So this is a patient I have who had a previous trabeculectomy in the right eye with a very good result, or so the surgeon would say. The pressure was 12, but he's feeling dysesthetic. His pressures in the left eye have been 19 to 23 on 4 classes of medications, and he's developed some cataract and some mild diminution of vision. And he is starting to notice some clouding of the vision in the left eye. He lives about an hour away from our office. His wife is in a nursing home, and he has very little social support at home. He doesn't have any children that live with him. This is his visual field in the left eye, which has been gradually declining, but maybe not so much as you would think for somebody who has a pressure in the low 20s and fairly advanced damage. The first question is, how low do we really want this individual's pressure? And the higher it is, the more we might tolerate either non-surgical therapy or less invasive surgical therapy, and the lower we want it, the more likely we're going to be considering filtering surgery. I think the answer was really provided very nicely from a study that's almost 40 years old by Morton Grant, who actually said that if you have a normal visual field but optic nerve damage, you tend to get damage if the pressure is in the high 20s or mid 20s, and so we often look at a target of the low 20s or around 21. If you have damage to the visual field in one hemifield but not the other, you will often get damage even if the pressure is in the low 20s or down to 20. And so we often go a little bit lower, around 18, to set a target pressure. And if there's damage both above and below fixation, then even you often will get loss even at the upper teens. And so we often set a target of around 15. So not much has changed actually in our thinking, even going forwards 40 years. Of course, we now also, as Madam mentioned, that we also consider pressures that are normal to be consistent with glaucoma. And so we have to revise some of these to say we should look for a different amount of pressure IOP lowering in patients who start out with a pressure in the normal range. Of course, you can think, well, isn't cataract surgery a pressure lowering procedure? And it does lower eye pressure, but not by much and not reliably. So this is a very nice study done by Steve Mansberger in Portland, who looked in the ocular hypertension treatment study in the untreated group. And of course, they had many, many pressure readings prior to surgery in these people. And they looked at who underwent cataract surgery. And they found that if you look at those who didn't, their pressure stayed the same. But those who did have cataract surgery, the pressure went down and kind of slowly went up, although there was sustained lowering even out to 3 years. I think the bigger point, however, is how likely are you to really get a pressure lowering? So, only about 60%, only about 60% or more fail to achieve 20% of IOP lowering. So you have, in fact, 11% who increase, about 20% who have a very modest decrease, and maybe about 32% who have a mild decrease of 10 to 19%. So actually, most people are not really decreasing very much. So if you're saying you're relying on this to get better, you can't really rely on this to lower the pressure, though it may on average. So for our patient, we want to set a target pressure based on his degree of damage and his prior course. He does have fairly advanced glaucoma, but even in the low 20s, he's progressed fairly slowly. He is older, but he's in tremendous physical condition, exercising every day. And so we might set his target around 20% below his progression IOP, or around 17. So with this kind of pressure, I think we can think about maybe glaucoma laser or drops not being adequate, and this is somebody who's likely to need some sort of surgical procedure. The second question that I always ask is how medication intolerant is this patient? And is it okay to continue the IOP medicines afterwards? If it is, then I think you can consider more strongly laser or eye drops or a less invasive procedure where you're likely to need medications afterwards. And if they really are not medication tolerant, and if they really need to be off medications, either for financial reasons or because of intolerance, then you're going to be more likely to consider a filtering surgery where you can really get the pressure low and get the patient medication free. Our patient has tolerated a heavy load of medications for many years. He's on 4 agents without any significant side effects, and he does not value getting off the medications heavily. And so we would consider a low IRP on medications a success. So I think that maybe lets us think more carefully about going ahead with a less invasive glaucoma procedure. And this is not somebody who necessarily needs filtering surgery. The next question is, would the unoperated cataract affect vision in the coming years? And of course, if the answer is yes, you're more likely to do a combined, and if it's no, you can more likely consider a surgery without a surgery as a standalone without concurrent cataract surgery. I think we need to be aware that really all of our treatments in glaucoma speed cataract formation. The role of the aqueous humor is to nourish the lens and to keep the lens clear. In fact, people argue about what is the most important structure of the eye. If you look at how the eye is designed, the eye believes that the lens is the most important structure of the eye. And in fact, you see that over here in your own practices by so many people being unnecessarily cataract blind. So you have aqueous humor to nourish the lens. When you make less, when you let it get out quicker, when you let it get out through a different pathway, all of those things cause cataract, and this has been shown for medications. It's not been shown for laser, but it's probably true. It's not been shown for minimally invasive glaucoma procedure, but it's probably true also. We should be clear, though, however, that unoperated cataract will definitely worsen after trabeculectomy. My colleague Henry Jampel, in his very humorous style, which those of you who know him will know, he wrote this editorial, "Trabeculectomy, more effective at causing cataract surgery than lowering intraocular pressure." And in fact, in one study that was true. At 3 years, 42% had a successful IOP lowering, and 50% needed cataract surgery. So in fact, it was more successful at causing cataract than it was at lowering the pressure. This is not universal across studies, but it's true in other studies such as the Collaborative Initial Glaucoma Treatment Study as well, where many eyes who underwent surgery needed cataract extraction, and in fact it was more than medications, and probably more than other types of surgery as well. For a patient who already has some cataract surgery, I think it would be silly not to very strongly consider a combined procedure for him. I think risk tolerance is something that Madam was talking about, really individualizing our therapy for the patient and talking to the patient. And I think we need to really understand our patients' fears and anxieties and really think about their risk tolerance and how risk averse they are. They give us a tremendous amount of faith by letting us operate on them, and we should be true to that faith and do things that are convey to them the amount of risk that is appropriate and which they're willing to tolerate. So when somebody is risk averse, I think we should be more mindful and more considerate of less dangerous operations such as laser or less invasive glaucoma surgery, which may not have the same risk file as trabeculectomy. And if there's really an urgent need to lower the pressure so that they don't go blind in the future, we can consider more aggressive options. So, of course, everybody is risk averse, but especially those who have poor vision in the other eye, who had a bad experience with prior surgery, and who have certain types of personalities, and we need to emote with our patients and understand these risks. So our patient had a mixed experience with trabeculectomy in the right eye. From our perspective, if we didn't talk to him, we might consider it a success. His IOP is well controlled, his visual field is stable, but he describes dysesthesia despite a low bleb. He has a lot of anxiety about surgery in the left eye, and this is his better seeing eye, although not by much. So I think that pushes us to maybe a less invasive option. And finally, we have to consider, do we want to do the surgery with cataract surgery, or is it better to do it without cataract surgery? And I think we need to consider how less invasive glaucoma surgery and trabecular glaucoma surgery change in their effectiveness with or without phacoemulsification. And so I think traditional surgery, especially trabeculectomy, may work better as a standalone procedure, whereas I think there's strong evidence that minimally invasive glaucoma surgery actually works better as a combined procedure. So this is in fact, many of these procedures have only been approved to be done at the time of cataract surgery in the United States. This includes the CyPass, this has been discontinued, the iStent and the Hydrus. We're only allowed to do them right now if done simultaneously with cataract extraction. And I think there is some evidence that trabectome and some of the other angle surgeries work somewhat poorly in phakic eyes as well. Cataract surgery, I think, is tricky because if we do it as a standalone procedure, I think it works a little bit better. But then it also risks that they'll develop a cataract, and then if you do that cataract surgery, then that the surgery trabeculectomy may fail afterwards. So you're caught in a bit of a catch-22. So I think we should consider it, but if somebody, especially a younger patient without much cataract, presents, we should probably be thinking of a standalone procedure. So these are some results. Of course, remember that these are only the results of those successful patients with different procedures. And if you can see, some of the surgeries that are more traditional surgeries, such as, say, ADI or Baerveldt or trabeculectomy, really can get lower pressures, and trabeculectomy in particular can get low pressures off of medications, whereas these minimally invasive glaucoma procedures, when done as a standalone procedure, generally require people to continue medications and only achieve a higher pressure. On the other hand, however, if you look at how these individual surgeries do when combined with cataract surgery, the results are often dramatically better. And of course, these are individual studies. You can see that all of them tend to shift both to the left in terms of lower pressures and downward, indicating less medication use. So I think once these are now done as combined procedures, we see that oftentimes they achieve lower pressures and with less medication usage, getting a fair number of people off of medications altogether. So I think for this patient who is medication intolerant, we can think very strongly about a less invasive glaucoma procedure, such as phacoemulsification and with a goniotomy or hydrous microstent. So what are our other guiding principles regarding phaco-MIGS and open-angle glaucoma? You have to think about their anticoagulation status, the cost. We'll talk about some of the cheaper alternatives today, including suture trabeculotomy, and I think Dr. Grover will show a video on bent angle needle goniotomy, which is a very cost-effective alternative to the dual blade. For people who are newer to angle surgery, you may want to try something simpler, such as the iStent inject or the dual blade. But if you really want to achieve slightly lower IOPs, the early evidence suggests that maybe the hydrous microstent or GAT is a better procedure. I think there's less evidence about what to do in people who are already pseudophakic. And of course, this is a complex space as well, because you have pseudophakic eyes which still have a closed angle, although those are fairly rare. You have pseudophakic eyes that had a closed angle and now are open, and you have pseudophakic eyes that were open and are still open. And each of those have to be treated a little bit differently. So I think when there was angle closure before, if there is still a closed angle, I treat it like a phakic angle closure eye. If the angle was closed but is now open, I tend to avoid angle surgery, although there's not clear evidence that you should or you shouldn't. And then there's eyes that that are pseudophakic, and I think they don't seem to get that additional benefit of doing a combined procedure. I think the preponderance of evidence suggests that they actually respond more like a standalone procedure as compared to a combined procedure. So I think we'll move on to hear about some of the other talks in this space, and I'm looking forward to hearing about all the specifics about how we do some of these procedures, and maybe having some time for discussion either as part of this session or after the session to really talk about the specifics of the procedure, whether it's something you would consider, and hear what your thoughts are and possible concerns are about doing the procedure as well.